My name is Shruti Kothari. I will be your moderator for today. I lead industry initiatives for Blue Shield of California, and we're focused on industry collaboration and alignment to scale transformative innovation. And today we have an incredible conversation planned for you all. We have Dan Brillman, who is the founder and CEO of Unite Us, Megan Callahan, VP of Healthcare at Lyft, Abner Mason, who's the founder and CEO of ConsejoSano, Alpa Vyas, who is the VP and Chief Patient Experience Officer at Stanford Healthcare. So if we could get rid of the slide and welcome the panelists. So we very intentionally wanted to have diverse stakeholders, industry leaders from different perspectives of our healthcare innovation ecosystem. You all do such important and amazing work, and also very different work from one another. So to get us kicked off, why don't each of one of you spend a minute or two just telling us who you are, what you do, and how do you support innovation?
Thanks for having me here today and the nice introduction. Megan Callahan, I'm VP of Healthcare for Lyft, 25-year healthcare IT industry veteran. And at Lyft, what we've done is, I know you all think of us as the way to get to dinner or in the movies in the days of yore. And what we've done is built a business-to-business platform, which allows health systems, payers, any healthcare social services organization to arrange for a ride and to pay for a ride on behalf of that rider. So we work with large healthcare organizations to administer transportation programs for their members, patients, riders. That is important because non-emergency medical transportation has been around since Medicare and Medicaid started in the mid-60s. But typically, this has been largely antiquated environment. Think large call centers, taxis, livery vehicles, shuttles, where you put 6 patients into a van, and it will take them obviously much longer to get to their destination. And what we've been able to do is obviously bring a very consumer-centric experience to that market to hopefully increase customer satisfaction, which we do, and also deliver a superior service at a lower price. And of course, get people to where they need to go to improve their overall health and well-being.
So I'm Abner Mason. I'm founder and CEO at ConsejoSano. And ConsejoSano is a patient engagement and patient health plan member navigation company. So we engage the patient or the health plan member and navigate them into healthcare at the right time in the right place. And the problem that we're helping our health plan clients and our provider clients to solve is that the country has become dramatically more multicultural over the last 4 or 5 decades, and our healthcare system just hasn't kept up with the demographic change. And that results today in a healthcare system in the US that just doesn't serve the country we've become. And that mismatch between supply and demand creates poor outcomes for people and higher costs for society. So what we're doing at ConsejoSano is we're using data, public data, private data, claims data. We add to that a team that is incredibly diverse and multicultural. And we are using the data to understand who people are at a much deeper cultural level. And then we design our engagement based on culture and add the right language. And that allows us to build a more trusted relationship. That personalized, more customized approach allows us to get patients and plan members to trust us, and that allows us to navigate them into healthcare at the right time in the right place. So we're all about using data to build a better relationship with people that produces better health outcomes.
Good afternoon, Dan Brillman, co-founder and CEO of Unite Us. We've been around for over 8 years, bringing healthcare, government, and social services together. And as a technology company, building what we call coordinated networks of health and social care providers. And so we are now in 42 states, about 500 plus team members. And this is a great conversation because 8 years ago, it was the first time we were bringing together stakeholders to securely share client data across sectors. And most importantly, track what is happening with a client outside of the traditional 4 walls of the medical community. And so the world that we've lived for the last 8 years is bringing a lot of these community-based organizations, thousands of them across the 42 states we operate, to effectively share data, not only back with healthcare organizations, but between each other. And the purpose of that is to obviously serve the patient or the client better, reduce the duplication of efforts, and of course, make the navigation of all these different services across across sectors much easier for the patient, not telling their story over and over again at different places where they show up to get the service they need that improve their health. So interoperability and structured data sharing across sectors has been obviously forefront to the work that we've been doing for the last 8 years. And thank you for having me.
I'm Alpa, Vyas. I oversee patient experience at Stanford Healthcare. And the way myself, my team support innovation is really through bringing patient and family insights forward, and insights can be in the form of qualitative and quantitative data from a user research perspective, really bringing that information forward to help our organization really think about how we might use those insights to develop services, products, or enhance features and functions around our patient portal. And kind of building off of what Abner and others have said, is that how do you create a more hyper-personalized experience with all the information and data that we actually have about our patients and families? So really trying to leverage information that we have within our systems to curate a much more personalized experience for patients and families.
Yeah. This is such an incredible panel, and I feel so lucky to have you all here today talking about data sharing. And for those who sort of are just joining the call, we asked the poll question to our audience: what comes to mind when you think about data sharing, essentially? And our top response from our audience here today was electronic health record is the top thing that comes to mind. And that was followed by privacy and security and health informatics. So wanted to set sort of this baseline of where the audience was at in association with these terms and concepts before we dive into the conversation of what does data sharing, health information exchange really mean for real health innovators who are scaling? So for all of you, the question that I have is, we know the ability to be able to share data across systems can have a truly impactful outcome on whether or not innovative products and programs can be successful. But in your view, now that we understand what work that you do and how you're progressing innovation, what does data sharing and health information exchange mean to you? And in your daily work, how can it support your work and in advancing innovation? So
I think of data sharing in what might be considered a standard view. So I think of clinical, financial, administrative, social data, standards-based, that can be freely shared, no silos, ultimately owned by the patient or consumer. Permissions and consent clearly understood, with an ability to opt in or opt out depending on the individual use case, which can vary. Ideally include unstructured data as well. As we all know in healthcare, that's where a lot of the meat is. And HIE as rails to kind of enable that. Previous to Lyft, I was on the board of the Commonwealth Health Alliance, which was an industry collaborative of the largest EMRs and other systems of record. So that's where it informs a lot of my thinking. And I was not surprised to see the audience say that EMRs were the first thing that comes to mind. If you think about data sharing and how it can support the spread of innovation, I think what we're seeing today is it allows new entrants to come in outside of these chosen few systems of record, like an EMR, like a clearinghouse, like a care management system, and unlocks that data to create new business models, and obviously the ability to do analysis in AI and ML and get to predictive type of interventions is incredibly important. Abner, I'll turn it over to you.
Yeah, sure. So thanks for that, Megan. I think from my perspective, certainly at ConsejoSano, a big focus of the company is reducing health disparities. We work with everyone, but there's no question our sweet spot as a company are multicultural, low income, low health literacy, undocumented, all the folks that are hard to reach and hard to engage. And if you include low income, it starts to include, a huge part of America. Our feeling is that we have to get beyond the talk and start to do something significant to reduce health disparities. And a lot of those disparities have a relationship to specific racial groups. And so I think for us, I believe that one of the only ways that we're going to make headway to reduce those disparities is that we've got to do a few things. One, we've got to collect race, ethnicity, and language data. If we don't start doing that as a country, as a healthcare system, we're never going to get serious and make real headway to reduce disparities. So first, we got to collect the data, and then second, we've got to identify the disparities, which groups and which disparities, and quantify that. And then third, we've got to put into place programs that address those disparities. And if you look at that whole picture, first, second, and third, what we need to do, it's not going to work if we don't have data, if we don't have a common repository for data, if we don't have a place where we can go to that is the source of record for information on people. So I think, if you look at it from a statewide perspective, which I think states are going to have to play a major role in reducing health disparities. Even when it involves federal dollars, the states are going to direct those dollars. We have to have a statewide data sharing and a statewide repository because we're not going to be able to make serious headway if we don't have those tools, the data sharing and the repository. So from our perspective, those two things are really important.
Yeah, that's a great point, Abner. And we actually at Blue Shield of California recently commissioned a white paper on this very topic of how HIE can support the collection of race and ethnicity data. Robbie, if you could drop that in the chat, the link to that article. Alpa.
Sure, thanks, Shruti. And I'll build off of what Megan and Abner just commented on. And I think from a individual patient perspective, I think health information exchange really becomes about empowerment. And so making information at a personal level available and shared across organizations in a meaningful way does begin to really help patients and their families create their complete health story, not having it trapped in disparate systems, and helping them kind of engage in meaningful conversations with whomever might be caring for them. I know from an academic medical center standpoint, not everybody is going to stay with us for their primary care. They may go back to their individual community and go back to a primary care physician or even a specialist within their own community. So how do we facilitate the progression kind of around their care plan in a way that makes it easy for them? Typically, when you're a patient, if you're sick, you're just coming out of a hospital stay, the last thing you want to do is try to coordinate all of the information and records that you've collected from whatever episodes of care you might have had. And so how do we do a better job of bringing that information, not only clinical information, but other kind of social data together to really help anyone who's caring for a patient and family member really create that whole picture?
Yeah, so I think fundamentally, no one organization or patient has a complete picture of their whole health or vice versa, right? So me individually, I've been to like 7 different doctors over the last 25 years, and they all have different pictures of me. And they all have little pieces of information. That's just the medical world. And then you bring in government services. I serve in the Air Force, right? Government has a lot of stuff on me, and I haven't even accessed benefits yet. So they're going to have a whole nother set of things. And then accessing social services, right? That is a whole nother set of data that I think Megan mentioned as well. So all of these organizations have individual sets of stories about a person, and no one has that complete picture. And shame on us, the patient doesn't even have that complete picture as well. And so for true impact, I think Megan said it really well, is how do we empower, and I'll say it as well, how do we empower the patient who really is, it's their data, to have that whole picture and put that together. And it comes in 2 parts, because there's the patient themselves or the client who needs that information to better navigate themselves through their life and their care. And then there's also each organization who has an incentive to make that person healthier too. And so they need the fuller picture. If you're an insurance company, you're a medical provider, you're a community-based organization, you're a state government, and you're on Medicaid or Medicare, it doesn't matter. They all want better data to do analysis as well to improve how they serve the constituents or patients. So it's really two-sided, and bringing all that together is the key. And the way you have to do that is both on the operational side, and what we've seen obviously over the years is how do you actually help securely share data for the operational purposes of getting people served? Sometimes it's harder to bring data together without that operational purpose. And then on top of that, say, how do we actually analyze this to better serve that population that we're serving as well?
Yeah.
Can I just add and build off of what Dan and even what Abner was saying, is that, as I'm just reflecting on what everybody's saying, to me, I guess data in this kind of way could be our biggest public health intervention to advance the health of many populations, because I'm just reflecting on what we've all been experiencing over the past 14 to 18 months, with COVID, whether it's understanding how do we outreach to patient populations that may not have access to vaccine, how do we actually tailor messaging that's personalized and meaningful to those that might be vaccine hesitant. And I think that, if we start thinking about information exchange as from a public health perspective, how might we move forward in a more impactful way?
Can I jump in there just for a second on what Alpa said? Because I think that we had a really very real experience with that at Lyft during COVID. So we estimated that 60 million Americans wouldn't get the vaccine just because they physically couldn't get to it. They wouldn't have transportation. And we did we've obviously engaged in vaccines in a number of different ways, both philanthropically and with customers. And we've worked with a number of government entities. And I think what's been really interesting to me is those government entities are doing reactive programs. When someone calls in to a call center, they will then say, can we give you a ride? But they really don't have the data in order if someone's vaccinated, unvaccinated, what kind of risk factors they have to kind of do, bespoke outreach to targeted populations in order to get them in to get vaccines. So that was something that we're seeing actually today. And public health data would really help with a true personalized experience to get to those populations that we really need to get to.
Yeah, that's a great, we did an event a few weeks ago, which was actually looking at the pandemic and the public health use case for an HIE, looking at other states and what they've been able to do during the pandemic. Robbie, if you can drop the link to that recorded panel in the chat. But that's a really great segue into the next question, which is around, other states that have a statewide HIE, a health information exchange. They have been able to use that to collect clean, structure data and data sharing in a way that has been pretty impactful. And there's some really specific examples on how that supported innovation scale. So the question for you all is, if we had a health information exchange in the state of California, what would that mean for your work? How would it impact it? And some of the gaps that you see, how would that support in closing those gaps? And maybe this time we will start with Dan, because I know you already work with states with a statewide HIE.
Yeah, thanks. And so obviously I think it would be great. It would lower a lot of barriers of data sharing. And I bring up Sync Health, which was formerly known as HIE, which is the statewide HIE in Nebraska we partnered with. And as an HIE, they're one of the most innovative organizations and working at scale, obviously across their state, but also working across states, which I think is really the future of kind of where we're going as well. And getting to statewide first is obviously great, and then working across that is, of course, the golden standard. But that means they're pushing innovation across the country, not just within the state, to enable better data sharing, to really ensure that we can take care of the whole person, right? Reduce the gaps of information that either physicians have or anyone in the medical community has that lead to ultimately fragmented service delivery. And our goal, our collective goal, is to focus on the best patient experience. And that requires both medical and social care delivery data, right? They may have one piece, we may get the other piece. How do we bring that together so that people that are serving that client at the right time have the right information to assess? And then also to take the right action, right? If you only have that piece of a story as a service provider, you're not there's no chance you're going to take the right action if you don't have the whole picture. And so they want to ensure patients are healthy. And what the best way to do that is to bring that together. Back to what I said a little bit before is the operational side, and then the analysis side, so they can get better at what Meg was saying, prediction, right? And we call it opportunities, right? These are opportunities for people to get Lyft rides. These are that otherwise would not take advantage of that. And so how can we be more proactive in taking action and serving people's needs? The last one is around structuring data. And so obviously Unite Us works with almost a new set of data in the eyes of the medical community. It's a lot of social determinants data, it's service delivery data around housing and things that may otherwise not be in the medical record or in an HIE. And this is around structuring data to start measuring impact with that, the medical data, which is great. And it's not just data on services and fulfillment or gaps, but really these outcome measures that continue to allow for shifts in funding, right? If you meet these measures, but you also need this data, then we will push more, dollars to make this better, which ultimately makes the patient experience better. And so I think that's what everyone is pushing for. But first you have to start, right? And first you have to start pushing that together. And that's been a really great experience. And I'd love to see that obviously across all states, as well as California.
I can piggyback off of that a little bit, Shruti. If you think about, I'll talk about, on a dream on top of a dream. So first of all, California having a statewide HIE is, one of the most populous states in the nation, and obviously a very fragmented healthcare industry, which would be fantastic. But to piggyback on Dan, I just want to set the stage on how someone typically accesses a Lyft ride for medical care. I think social service is a little bit better in asking the right questions. But if you go in and let's say you have a chronic disease and you get a care plan and you don't have a ride, if you're Medicaid or Medicare Advantage, you typically get a card with a 1-800 number on it. And you're going in, you're calling into a call center, you're booking that ride 72 hours in advance. If your appointment changes, you got to call back in. It's very much at the behest of the actual patient in reaching out for help. Now, getting back to what Dan was talking about, data is everything, and it's really key to the momentum, I think, around social determinants of health in general, as we're all prioritizing those investments in order to get better streamlining and embedding data collection into the provider workflow. So right now, we really need a standard coding system that would allow for more in-depth analysis to evaluate different types of social care interventions that would drive results for different populations. For example, we can measure how health outcomes of a patient change when they have access to reliable and affordable food or reliable transportation. So at Lyft, we joined the Gravity Project, which really aims to integrate SDOH data into the digital infrastructure in a standard-based way, so that as an industry, we can track who a physician could screen for this. It could be part of the digital infrastructure. And then we could look at what policy interventions, what programmatic interventions are really improving health outcomes. So those codes, I hope, will be at Snowbend was accepted. I think the ICD codes are hopefully in October of 21. So hopefully we can start using those more than 2% of the time, which is what they're used, the existing codes are used for now. And we can get those into a California statewide HIE.
A lot of our clients have asked us to do what we call COVAX work. That means that a lot of our plan clients, for instance, asked us to survey their members to see where the members are in terms of their willingness to get a vaccine. Either they're excited about it or got it, or they're hesitant, they're not sure, but they're not a hard no, and then the hard no. So it's sort of three buckets, I want it, not sure, and no. And so we are doing that for a lot of our plan clients. And it's interesting that it makes clear that if we had better data, and again, it goes back to race, ethnicity, and language data, but other data as well, it would allow us to tailor our interventions much more effectively. We could, for instance, know that not just that there's a middle bucket of hesitant, but within that bucket, it's Latinos who are 50 and over, and we need to design an outreach campaign for Latino men, for example, who are 50 and over. That kind of customized outreach is really needed, and we can't do it now because we don't have that that data, certainly in a robust statewide way. So, but to follow on Megan's dream on a dream, I'm going to add a dream. So on top of that, I think we ought to, what I would say, imagine this: if we could we could take the STAR rating program in the Medicare Advantage program and the HEDIS quality measure program in the Medicaid program, and we could tie those ratings so they're in part based on closing health disparities. It would transform, it'd be a big step towards transforming healthcare in the US. Because if you could get all Medicare Advantage plans and all Medicaid plans to actually start to say, this is something I need to do in order for me to be successful as a plan. The way I'm going to be measured is reducing, these healthcare disparities. That's what I call a flywheel effect, where they would start to say, okay, we want to invest more in solutions. It would generate innovation. They would reach out and find partners to work with them. I think that should be I'm hoping, fingers crossed, that's a big part of the future of those programs. But the infrastructure, the necessary infrastructure to make those kinds of things a reality is data sharing and statewide HIE. So these things go together, and it's exciting to think about it. But we need to lay the groundwork, and the groundwork are these statewide data sharing and HIE repositories.
Very well said, Abner. Thank you. And Alpa.
Yeah, no, I am very much supportive of what my colleagues on the phone have said. And maybe I'll just add a little bit of perspective. I guess the way I was thinking about it and listening to others' comments is really that, data is our currency right now in creating value for the patient, right? And for the family members that a statewide HIE would, I think, drive to what Megan and both Abner and Dan were talking about is the outcomes, so the clinical outcomes, right, for a patient, as well as the experiential outcomes that they might be desirous of, or that we as an organization are desirous of. And then really thinking about the ability to access that information in reducing the overall cost of care, which we know is really important to patients. It's a very expensive proposition interacting with the healthcare system. And then finally, how do we actually make things easier for the people who are interacting with the system, meaning the physicians, the care teams, the administrators, all of those folks? Because right now we spend an inordinate amount of time kind of managing the work in between. And we also offload that work on our patients. I think Megan brought that up, is that if you are experiencing a health issue, especially if it's acute, it can feel very burdensome to navigate a very complex system, whether it's for information, for access to care, et cetera. And again, I just think about from an academic medical center perspective, unlocking that data really will allow us to understand from genome to intervention, right? And really think about that notion of personalized care that others have talked about.
It's been incredible to hear all of you talk about it from your seat in, again, the healthcare innovation ecosystem and how you're innovating, and how something like data sharing, a health information exchange could actually really support your work, advancing it, closing those gaps. So last question before we move on to audience Q&A. For folks that are still skeptical about, you guys have talked through this work and given great specific examples, but for anyone on this line that still doesn't really believe that data sharing can help to really improve outcomes, really help to scale innovation, what would you say to them? Any last closing remarks? Abner, you look like you're ready to go.
It's a good question. So politely, I would say I'd say if they don't believe in data sharing and a creation of a statewide HIE, I would challenge the skeptics to identify another efficient way to address health disparities. I know I'm harping on that, but it's what we really focus on, and I think, frankly, our country needs to focus on. We've got to make our healthcare system work better. And so I would challenge them, find another way to do all the things that we know are necessary, which is to quantify, to be able to target programs, to be able to measure effectiveness. If they got something better, put it out there. But I think that, in my view, if you're serious about reducing healthcare disparities, it leads inevitably to supporting, data sharing and the creation of these kind of statewide data repositories.
Shruti, I'll add on. I would just say, put yourself in the place of the patient, right? As patient experience leader, we start with empathy, and imagine how much more complicated, or maybe on the opposite, how much more simplified the experience could be for someone as you think about navigating, again, a very complex system. And I also think about what other industries are doing by leveraging data to create personalized experiences. We all interact with data in other industries all the time. And when we think about those hyper-personalized experiences that we get interacting with other parts of or other industries, we owe it to patients and families to really try to adopt that similar mindset. And I just go back to really focusing on the opportunity we have to advance public health.
Yeah, Alpa is right. I would charge that person to try to go get 3 different types of services from the medical community, the government services, try to get enrolled in SNAP, and try to go, housing or employment services in the community, and try to tell your story once, right? That's the problem. And I think if you haven't experienced that, once you see it, I mean, that's how we started this company. I was trying to help veterans that held all different types of needs, and I tried to help them all by trying to go to all these agencies myself for them, and I saw it firsthand. And I know we talk a lot about the medical community and data sharing inside just the medical community, and I see some stuff in the chat about FHIR, and I think there's a world where we're already extending those applications into the community as well, and adopting FHIR standards beyond just a traditional medical exchange, which is where the world needs to go. But I would charge them to go try to get different services, and a lot of people, I think, that maybe pushing for some of the things, or that are skeptics, right, have not experienced that to the full extent, whether that's either for themselves or caregiving for someone else. But once you've experienced that, then I think you'll be a pretty good steward for the change that we need.
Yeah, so I'll just say, I think we can probably all agree that COVID has laid bare many, many of the inadequacies in our healthcare system today. Certainly, you all have talked about what a better public health infrastructure on an HIE would have allowed us to do during COVID. If you think about where we've been as an industry, we've really been working on, standardization of healthcare services, because we had such a large population and things were being decentralized, et cetera, et cetera. I mean, between COVID, between what we're doing now with technology in terms of remote monitoring, continuous monitoring, care in the home, et cetera, we're going to have this treasure trove of new data sources, and we need to unlock the old data sources to pair with those to really get a bespoke view of that patient, to get to some of these better interventions that we all talk about. But right now, we don't have the infrastructure outside of pockets to really deliver in a fulsome way. So.
And maybe heading into our Q&A section, maybe we can just spend a little bit more time talking about FHIR. Dan, you brought it up. We've seen the comments in the chat. But the question comes to us, do you think FHIR standards are the answer to the fragmentation problem? This is always front and center. Curious, why FHIR wasn't mentioned. So if you want to, I know you started to get on the topic, Dan, if you want to continue.
Yeah, it's definitely an answer for sure. And I think there's obviously there's many iterations over the years of HL7 but FHIR we're seeing it adopted more and more. And I think we all need to be good stewards as well to help others adopt it. And so as a company, we've spun out our own interoperability team that helps organizations that have not adopted FHIR yet, even medical organizations, help them adopt FHIR, whether it's setting up servers with us, like there's all different ways to do that. And I think it is a really good answer, because we can all get around that common answer without trying to fragment it more. Is it going to solve every part of it? I don't think so, but I think we're seeing barriers come down a lot from both the medical side and even government services, looking at FHIR to do that. So it is an answer. I don't think it's always going to be the answer, but I think probably 12 to 18 months from now, you'll hear it more than you already do today. So, but it's a great question.
Another question, how do you break down competitive barriers that at times block data sharing? Do we need to look at regulation or policy?
I'll jump in there again. I think it's twofold. We've seen regulation come out to lower the blocking of information, right? Ultimately, this is about patient data, so that is becoming more forefront, for everyone. So I think that's great. And also OCR they're also receiving comments now on lowering the barriers to data sharing, right? There are regulations that are in place that do limit the patient's experience getting services, right? And some of them are a little bit antiquated. Some of them just have changed because need to change because technology has changed. And you've seen HHS and OCR put out comments to the community, the larger community, to say, hey, where are we doing this right? Where should we change? And as a company, we've added plenty of organizations. Blue Shield tagged on with us as well. Many organizations to say, hey, we need to do this. One, it's got to be secure, right? We have to keep the patient and their consent in mind. But we can't have blocks when it is better for the patient or for the provider to have that information versus, sorry, you can't have it at all, because otherwise they're not going to know how to serve them, right? So there are things that don't make a lot of sense. And I think those have come to the forefront because interoperability and data sharing has become so paramount, and especially not just in the healthcare industry, but across technology. And so those changes are readily happening. So that's also great to see. But policy is a great way to obviously do that, and showing how it does work when you do lower those barriers and how it does improve health.
Shruti, can I just add, as healthcare is so fantastically regulated, many of us just have full-time jobs managing and understanding what the latest regulations and policy changes are. The alternative is, before the regulators kind of put policy in place that we all then have to kind of bend to, is a better way thinking through what's the incentive, right, to actually participate and break down those barriers. So collectively, as an industry and people who are interacting and caring for patients, how can we be more proactive or use incentives as the lever versus just a pure policy or regulatory play?
And I just add, I think that going forward, we're going to see consumers putting pressure on the system, whoever that is, because Dan's right. It's the patient's data. The system is set up today in a way that it really isn't the patient's data. Everybody else has got it, the patient doesn't have it, and the people who have it, they want to keep it and hoard it. And I think that ultimately, we're going to see healthcare consumers forcing change. Now, they may do that through the policy, approach by going to their elected representatives. But a lot of times, I think they're just going to vote with their feet, and they're going to move towards solutions, new innovative solutions that treat the patient with the respect the patient deserves. And key to that is this recognition that it's their data. And so I think that's coming, and I think consumers are going to be a part of pushing us in that direction.
Yeah, I was just going to say, I agree with that. I think we have to get consumers to know that the status quo is not necessarily the way it should be, right? And it's going to be a huge re-education for Americans. But I was just, I think that we have seen regulation in this area, right, and policy in this area through Blue Button and ONC and everything that they've done. And back in the early days when we formed the Commonwealth Health Alliance, right, which was large EMRs getting together, there was a large EMR that was not part of that. They had their competing initiative, and there was lots of conversations around, in a particular geography. How can we ensure that all of the health systems could share data equally and there were no holdouts? And we did see big progress. It took a while, but we did see big progress there. So I'm hopeful that we'll start to see more accelerated change. And certainly this topic is way more top of mind than it used to be.
Yeah, absolutely. Another question, how do you propose aligning incentives with large EHR providers to integrate their systems to enable data sharing?
A piece of that is our innovative companies who are coming up with like APIs that allow for the sharing. And so again, I think innovation and technology solutions are going to be part of how we get there. A lot of companies today are using, the APIs that allow them to take data from what are pretty isolated, siloed EHRs and to be able to, export it and use it. So I think there's a lot of future there, but I think these entities have a lot of influence, and so it's going to be hard, and let's face it, change, we always try to think that change is going to be great for everyone and no one is going to suffer from change. I think we have to be realistic and say that sometimes when you have a system that is as that works as inefficiently as our healthcare system does, positive change means that somebody's, ox is going to get gored, is that phrase. And so, I'm not, and I understand I'm not being insensitive to it. I know people have put a lot of investors and other people put a lot of money behind certain solutions and certain companies, and we've got to work through that. But I think we got to work through it with the idea that change means sometimes people are going to have to, business models may have to change. We've got to accept that. And it's hard to accept, but, that's the way it is.
Yeah, I mean, I think data has been a big strategic differentiator, right, for decades now, and people have been protecting that as a competitive differentiator, which is understandable. I think my hope is, yes, there's a policy regulatory lens to that, right? That certainly has a role. I also think that as care gets dispersed outside of what are traditional settings, whether that's acute or outpatient care, and new companies come in to try and enable care in the home or really health care, not sick care, I'm hopeful that we'll need to move to more data sharing.
Yeah, if I can just add, I mean, there is a forcing function, and I kind of joke internally that the Cures Act actually took an act of Congress for some information to get into the hands of patients. Literally took an act of Congress. But how can we really think about creating the right model to incentivize the liberation of personal data? I think what's going to happen is as patients and or other consumers of healthcare are going to figure out a way to do it. Other companies are also thinking about how to do it. So either, these larger providers and companies can lead the way, or there's going to be some level of disruption, because I think everybody recognizes that the need is there. And I still think back to COVID, right, with the expansion of things like video visits, the now focus on things like remote patient monitoring. As technology companies start integrating, this level of health information exchange and integration of data is going to be key. And I think, Megan, you said it, like the way care is being delivered, or health is being delivered, is changing. So it's either going to happen to us, or we can watch or read the tea leaves and say, how do we kind of help ourselves to help our patients?
Yeah, absolutely. Last question. I think that was a great setup to this last audience Q&A before we move on to our last segment of this session. But what is the role of payers, plans, other partners that pay for services in progressing data sharing, advocacy for it, so on?
It does. The last question kind of ties into this. As Megan said, a lot of people have used data as a differentiator. And so I think plans, though, are in an interesting position that I see health plans, as opposed to providers and provider systems, as having a bigger interest in the sharing of data. And so I think you're going to see a bifurcation. Plans are going to be on the side of wanting to share more. And I think you're going to see providers and health systems a little slower to get there. Interestingly, a lot of health systems now are taking risk. And so they're going to start to, they're going to think with two heads. Part of it's going to be a fee for service, old way of thinking about their hospital. And part of their thinking is going to be a new way, because they're taking risk on patients, and they're going to see the value of data sharing there. So I think because of the influence of plans, I think they're probably the biggest player in healthcare in the US. They certainly spend most of the dollars flow through them, or I think they will be on the side, more on the side of sharing is my perspective. And I think that's a good thing. They're slow to move, but slowly they're moving towards saying this is this is better for the health system. Not that I don't love the providers and the health systems. Don't get me wrong.
No, I don't.
I'm looking at Alpa. I love you.
I don't disagree, Abner, with what you said, and I would think that as we've been talking about moving to value-based care for I don't know how many years now. Too many to count, but if we start to really pay on outcomes, then you have to share data because you have to be able to measure that outcome across various settings of care, right? Various payers, et cetera, et cetera. So, and you have to track that over time, right? Where you might not be with the payer for that entire time. So I'm hopeful that will also enable people to get on board.
Wanted to leave with a call to action. So, we've talked about build up the use case. Why is data sharing important? What does it actually mean to innovators, all these amazing innovators on the line, whether you're on an enterprise side or a startup side, doesn't really matter. It's really important. And we wanted to give really specific examples of why it is important. And wanted to end with Timmy Leslie, who is from Blue Path Health, and she is also the facilitator for Connecting for Better Health, which is California's coalition dedicated to health information exchange. And they have a fantastic educational forum where stakeholders essentially join to learn and shape policies for the state of California. So I will hand it to you, Timmy.
Thank you, Shruti, and thank you for the introduction, and thank you, panelists. What a fantastic discussion. And if I'd had my video on, you would have seen me smiling the entire time that, to be able to have a whole dedicated session talking about how we can advance our policy goals, the California's goals around, reaching their policy goals through data exchange is just really terrific. And just to introduce with this PSA, we do have a forum that we offer for all of you to join. It's called Connecting for Better Health. We'll put the URL in the chat, and it's a place where we get together on a regular basis, share stories, patient stories, provider stories, and also look to how we best can advance our policy aims. And I'll go into that in a little bit. But I think, as Shruti said, we thought it would be great to be able to share one of the patient stories that we collected, just to bring this home as to why it's important to keep the patient centered in this discussion. Kira, do you want to start the video?
I'm 23, I live in LA, and I have juvenile dermatomyositis. I have had extreme difficulty walking. I've developed arthritis in my knees and my hips. I was on chemo during high school and at the beginning of college. The fatigue made it really hard for me to not only get through full days of work, but even get through homework. Sitting up in a chair was really hard. And so on top of that, I was really expected to also manage my medical records. Okay, so this is only 2 years worth of my history. I go to all these doctors and they have no communication with each other. If I were to have any sort of accident that made me unconscious and I ended up in the ER, I would have no way of telling them my medications or my diagnosis. On the outside, looking at me, I look completely healthy. So there would be no reason for them to assume that I was dealing with all of this stuff. All that pressure cannot be put on the patient and their families.
So I thank you to Anna for telling her story. And I would encourage all of you, if you have a story to share, please send it to us. And then also we are inventorying these stories and putting them up on our website. And I think it's a great way to be able to start board meetings, end board meetings, and remind us as to why we're really looking forward to advancing data sharing in California. Just to go to the next slide, just to give you a sense of our policy aims. We founded the coalition on 3 principles. The first is to compel participation. And I think that's really what we were kind of digging into at the end of the session is how do we incentivize before we move to regulation or policy or even legislation to be able to ensure that we break down those business barriers or technology barriers to share data. So that's, policy 1. And then 2 is looking at other states and then also looking at California and how large we are the federal dollars that are available to us are just not being tapped right now. So that's also an ask that we have to be able to bring additional federal dollars to build the infrastructure that we know we need. And then the third principle or policy aim is to really build on what we have today, whether it is based on regional data sharing that's happening in different geographic areas across the state, or private networks, but how do we kind of glue that together or make that patch that together, as well as compel the state to be able to share their data resources. And I just want to point, based on this discussion, that we are looking at, in addition to health data, but also social services data and public health data. And to Abner's point, race and ethnicity data is really key to data collection across the state. If you want to just go to the next slide, Kira. Again, we are, as part of the coalition, we are tracking the state goals as well as the legislation. So it's a really good place to get smart and also share your knowledge and where we are with policy advancement. So again, this kind of tracking is available and it's up on our website under resources. And finally, I would just ask that, again, to the call of action, Shruti, if you are compelled to be part of the conversation, Carrie, you can just go to the next slide. Join us and we'll add you to our now weekly calls because we are running really fast and furious to be able to keep track of what's happening at the state with those two bills and also the legislation, or not only the legislation, but the governor's budget that we're tracking very closely. And as we move forward, we will be making sure if there is any policy advancement this legislative session that we create an accountability framework to ensure that it gets implemented. So with that, I'll just end. We welcome you. We want our tent to be as big as we can make it. And again, thank you for this PSA and the reminder, Shruti, as to why we want to put the patients and the providers at the center. Thank you.
Thank you, Timmy. And a fun fact, everyone on the panel today is actually a part of that. I think most people are a part of that coalition. So really exciting. You saw the list of organizations involved in the coalition. It's really a great group of systems, plans, innovative companies, community organizations. So if you felt the conversation compelling today, really, no matter what seat you sit in, whether you're an innovator, whether you are an administrator, whether you're in the community, data sharing will have a huge impact on the work that you do and your ability to improve outcomes and to scale innovation. So thank you, panelists, again, and Timmy. Really appreciate you being here.